Welcome to the Gastro Girl podcast. We bring together patients, experts, and health advocates who are all here to help you optimize your health. Here's your host, Jacqueline Gaulin.
Hey everyone, welcome to the Gastro Girl podcast. Today's episode is brought to you by Ardelyx, and we're honored to have Dr. Lin Chang joining us today. Dr. Chang is the Vice Chair of the Vachi and Tamar Manukian Division of Digestive Diseases at UCLA, and she also serves as the Program Director of the UCLA GI Fellowship Program. Additionally, she is the co-director of the G. Oppenheimer Center for Neurobiology of Stress and Resilience and Director of Clinical Studies and Database Core at the Goodman Luskin Microbiome Center at the David Geffen School of Medicine at UCLA. Now, Dr. Chang is a renowned expert in neurogastroenterology and the gut-brain connection, making her the perfect guest to help us explore treatment options for IBS-C and guide us on how best to navigate treatment plans when they're not working. Welcome, Dr. Chang. So nice to see you again.
Thank you so much, Jackie, for having me. I feel honored to be here.
Oh, thank you. Well, we get so many inquiries with patients that are struggling to manage their IBS-C, as I'm sure you're well aware of in your practice and in your research. So before we get into all the nuts and bolts of the options, can you just give us a brief overview of what IBS-C is and how that differs from other types of IBS and other types of constipation?
Yeah, so I think the general term IBS is probably more well known than the actual full term, which is Irritable Bowel Syndrome. And so it's really well known as IBS. And that means that patients have chronic or recurrent abdominal pain or discomfort that's associated with diarrhea, constipation, or both. When a patient has pain and discomfort that's associated with constipation, we call it IBS with constipation or IBS-C, as opposed to IBS with diarrhea, IBS-D, or IBS-M, which is IBS mix, where they can go back and forth with diarrhea and constipation, which, is challenging.
Yeah, it's so complicated. So is there a differentiator between with the irritable bowel syndrome and just regular constipation?
Yeah, that's a good question. So IBS, I should say, is a symptom-based disorder. So you make the diagnosis based on the patient's symptoms. There's not a blood test or, an x-ray that shows that, like you can get for diabetes or high blood pressure, hypertension. So it's all based on the symptoms. So the patient's history is really important. And that is one message I would give to listeners, is that when you're communicating with your healthcare provider, is really understanding your symptoms and conveying that. And also the provider asking you the key questions is really important. So when we think of chronic constipation, which means that patients have constipation symptoms for at least 3 months, there's some main types. There's IBS with constipation, which is pain associated with constipation. And then if you think of chronic constipation, which means that you don't have predominant pain, you have mainly constipation. And there's actually 6 signs or symptoms of constipation that I'm sure not everybody knows. And you have to have 2 out of those 6 to meet the criteria for chronic constipation. But say you meet that criteria. There's slow transit constipation, which means that the stool and movement through the bowel is slower than normal. It could be normal transit, which is interesting because the patients still feel constipated. And then the other type is where it may move through the colon normally. It could be slow, but the patient can't evacuate properly. So we call that defecation disorder. They have other terms. So that's how you think about it. And the treatments could be different. And that's why you want to think about the mechanism by which they get constipation.
Yeah, and that's what we really want to get into today, because I really appreciate how you set that up, because a lot of us may not realize that there are so many ways that this constipation, IBS-C, presents itself, and even with constipation. And the questions that your doctor should ask are important. Can you just give us a few of what they're going to ask you? Just because I think it helps patients think about their systems in that way, and preparing themselves to have those conversations.
I think the important part for patients to be prepared to convey what is bothersome, what symptoms are bothering them. And they should really focus on the predominantly bothersome symptom. Because as I said, people can have different symptoms. If you and I both had chronic constipation, you could say my most bothersome symptom is I have a bowel movement less than 3 times a week. I just don't go very frequently. And I could say, well, I go almost every day, but I really feel like my stools are hard. I'm straining all the time. It takes me a long time to evacuate. We could have different symptoms, but we could still both have chronic constipation.
Or IBS-C, like if I have a lot of pain, like, oh my God, I have so much trouble going to the bathroom and I have this awful pain.
Yeah.
That's when you know it's IBS-C.
Right. So what's interesting about IBS-C is often patients come to the doctor because of pain, because that's a really bothersome symptom. And they could say, when I get pain, I get constipation as well. If I go to the bathroom, my pain could get better, partially. But what's different about chronic constipation is they may have pain if they don't go have a bowel movement for many days, because you can hear that. Where pain is not a predominant symptom. An IBS-C patient, they can have some regular bowel movements, but they still have pain. So it's because their gut's more sensitive. We call it visceral hypersensitivity, and they have a motility problem, meaning the stool doesn't empty as well. Where patients with chronic constipation might not have that hypersensitivity pain component, but they still don't have proper bowel movements. And that's the difference. And why that's important is because some medicines help you go to the bathroom, but some of them can help pain as well, but others don't help pain as much. It helps you go to the bathroom more normally, but you can still have the pain. And that's why it's an important part to convey to your healthcare provider.
And this is why it's so confusing for patients. We don't know what to take. How do we know? So if I'm your patient and I come to your office, you diagnose me with IBS-C, I have this pain. What is the protocol? How do you start me off? And what happens if the first line treatment, whatever that is, doesn't work? What's next? And how do you figure out what product or what treatment I need based on the mechanism of action?
Well, as I said, you ask the patient about what's their predominant symptoms and what does the patient want to be relieved. And then I think a good way to approach it is think about the symptom as mild, moderate, severe, very severe. And mild means that the patient has these symptoms, but it doesn't really impact their quality of life. They can still go to school, they can go to work. It's somewhat bothersome. And many times they just need diet, lifestyle modifications. They often want just to take something over the counter. The moderate severity is where the symptoms are starting to impact their quality of life. They may miss work or school. They may have to spend more time in the bathroom and they have to go to class later or start work later or work at home. They can't go out to eat as often as they want. Severe means it's much more of an impact on their quality of life. So when you get to the moderate symptoms, you can try over the counter and diet like fiber, but often you need to start using prescription medicines, and there's different ones. And then severe, you want to do everything you're doing with mild and moderate symptoms, but there you might want to add other types of modalities. Sometimes you even use combination therapy, depending on how they respond.
Oh, no, this is really interesting. Can you walk us through the different types of prescription medications, and then we can get into the modalities that could kind of work together for patients?
Yes. Oh, so before I go into, I'll just mention fiber because I think many people are interested in that. And the type of fiber that's been most studied is soluble fiber, like psyllium. And that can help bulk the stool, make it move through and be evacuated better. A lot of people want to drink fluids, exercise. And I think that all helps, but often that is not always effective. The patient can still have constipation, but you want to do both of those. And then we have prescription medication for IBS with constipation or IBS-C. So one of the older ones is lubiprostone, which is called Amitiza, but is now available as a generic medication. And then there's linaclotide, which is Linzess, and plecanatide, which is Trulance. And they all work in a similar way, which is to secrete or move chloride from the bowel into the bowel lumen, the center of the bowel, and sodium follows in water. So it's like putting salt water in and then moves the stool through the bowel well. And these medications can also reduce pain, which is a bothersome symptom like we talked about. Then we have a newer agent called tenapanor. It's also known as Ibsrela, IBS-Rela, and that works differently. It blocks the reabsorption of sodium and water into the bowel, so it keeps it in the lumen of the bowel, and that helps move the stool through the colon. It can also reduce abdominal pain. And one of the main ways it's thought to reduce abdominal pain is by normalizing the lining of the gut so it's not as, quote, leaky. And I'm sure you've heard that term leaky gut, which is a lay term, but it really means that there's increased intestinal permeability. And that's been linked to abdominal pain. So if you can normalize that with a medication, that could help abdominal pain.
No, that's interesting. It's great news for patients that there's so many options, but then it's also confusing for patients. How do you know which one to take? And I know every patient's different. And this is why we want to stress the shared decision-making and the partnership with your healthcare provider. So how does that work? And what are your tips for patients who may be starting down this path and trying to figure out what medication works best for them?
Yeah, it's a really good question. Well, it depends on what has the patient tried before.
Right.
And what does insurance cover? So it's cost. So there's some of those issues that have to be dealt with. The Amitiz or lubiprostone and Ibsrela are twice a day, and Linzess and Trulance are once a day. So that's one thing. But they're all, capsules, tablets. So if somebody has more pain and constipation, typically I'll more likely use Linzess or Trulance or Ibsrela. There is some data that lubiprostone, Amitiza could be helpful, but I think the data is stronger for the other three. Linzess is nice because it has 3 different doses, and sometimes you can't really determine what's the right dose for the patient, so they have to try different doses, where Trulance has 1 dose. And Ibsrela right now, since it's newer, which is typical for any new medication, is you can't easily get it as the first medication you try. Sometimes you'll have to try Linzess first, and if that doesn't help and relieve the symptoms or the patient doesn't tolerate well, then you can get Ibsrela. I'm sure at some point everybody could get all of them, but usually when it's newer, you have to try something else first.
No, I like how you segued into that, because one of the questions we get a lot from patients is, I don't think this treatment is working. How do I talk to my provider about switching? And also you want to give the first thing you try enough time. So how do you navigate that with your patients?
Yeah, I mean, that is something to really think about from even before that, which is what symptoms are you targeting? Does the patient know what the medication is for? Because sometimes they're on a lot of medications and it can get confusing which medication is for what
Right?
condition or what symptom. And also the expectation is, when is it going to work? So if patients think that it's going to work immediately in 2 days, that my pain and my bloating and my constipation is going to be normalized, then that's going to be the wrong expectation. It's not realistic. So often these medications can help your bowel symptoms and constipation earlier, a couple of days, weeks, But bloating, pain, discomfort take longer, usually. It could take 3 to 4 weeks. So the patient needs to know that before I say that a medication doesn't work, I need to give it enough time, and I need to know what I'm looking for. And when they go back to the provider needs to ask, did it help any of your symptoms? And if it did, what symptoms did it help and what symptoms did it not help? Because maybe the patient wants to stay on it, but they need to add something else. But they may say, look, this is not helping me. It's not giving me enough satisfactory, adequate relief of my symptoms. I'm still having this symptom. And then it's time to try a new medication, as long as they've given the other one a good try, because you don't want to cycle through too many medications too quickly and then you run out of medications to use. So just needs to be a thoughtful approach. But I think many times in providers, and you have this short time with the patient, do you feel better or you didn't? And sometimes that's just not a good enough, meaningful conversation. It's more, what was your experience with it? What did it help? What it didn't help? And then what's still bothering the patient from the viewpoint of symptoms, and what do we now still need to target and improve?
Those are really good points. And you have me thinking about, you've done some pretty powerful research over the years. I've known you for a long time, and your work in the gut-brain area and the neurogastro area is so important. How can we talk a little bit about how those modalities, the behavioral health, play into this? And when you're working with your patients, do you recommend a multidisciplinary approach like that, even with diet too?
Yeah, so IBS has now been termed disorders of gut-brain interaction, DGBI, which is not a easy thing to say, but it just means that these collection of conditions, there's scientific evidence that the way the brain and the gut communicate can become altered or dysregulated and lead to the symptoms, and it could lead to changes in motility, constipation, diarrhea, but also this increased perception and the visceral hypersensitivity in the gut of pain, discomfort, and pain, discomfort, and bloating, which are bothersome symptoms. So some of the treatments can work only in the gut and help that. And some treatments work in the gut and the brain. And so there's some treatments that work mainly in the brain, but then downstream helps the gut. And one of the treatment areas that you were alluding to is what is called now brain gut behavior therapy, or we used to call behavioral therapy. So there's increasing evidence that behavioral therapy, like gut directed hypnotherapy or cognitive behavioral therapy for IBS, mindfulness based approaches, can help patients in the way they perceive the symptoms, in the way they manage their symptoms, and reducing the bowel symptoms themselves. Because the brain and the gut are connected. And whether you're going to target the gut, you're going to target the brain, it could help that communication, that highway between the brain and the gut, and normalize to relieve symptoms of IBS.
We still, after all these years, see patients, and it's really heartbreaking when they say a comment like their doctor thought everything was in their head, or their family thinks it's all in their head. So the patients think there's something wrong psychologically with them because they have an IBS-C issue or something like that. What insight can you provide patients along those lines?
Well, we had talked about how IBS is a brain gut disorder, and it's the way the brain, the gut communicate, and it could lead to these GI bowel symptoms and abdominal symptoms. But just because the brain is involved, which is involved in a lot of functions in our body, it doesn't mean it's psychological per se. Now, I will say that if somebody has psychological symptoms like anxiety, depression, there is an association with IBS. But they did some studies many years ago that show that if you look at the general population and measure psychological symptoms, it's pretty similar to the general population. Having psychological symptoms does increase healthcare seeking, and it is more associated with the more severe symptoms. But these symptoms are real, and there's brain imaging studies and many other scientific studies that show that there's physiologic changes, that it's not imagined. And that's so interesting that I feel like in life, it's like we have to see something structural, concrete to believe it. But there's so many emotions and feelings that we have that we don't have proof, but we know they're real. And this is a real condition. It's a very common condition.
No, thank you for that. And since we're on this path, we've also had patients who tried everything. And then what we've been hearing more and more is about the pelvic floor's involvement in some of these issues. Can you just provide a little bit of insight on the relationship between something like an IBS-C or chronic constipation as it relates to the pelvic floor?
I'm so glad you brought it up because that is such an important point. So in some patients with IBS-C or chronic constipation, I had mentioned that they can have a defecation disorder, and part of that is having a pelvic floor disorder. And the terminology we use is dyssynergic defecation. Basically what it means is that the pelvic floor, which is continuous with the anal sphincter muscle, the muscle right at the opening, the exit of the gut, cannot relax like it should when you're trying to evacuate your stool. And if it doesn't relax, it doesn't allow the rectum to straighten up from a 90-degree angle to straighten up and the pelvic floor to relax and evacuate. It just stays more contracted, like tense. And so the treatment would be not just constipation medications, but anal rectal biofeedback, where the patient's retrained to use the proper technique, or pelvic floor physical therapy. And I tell my patients, we don't remember when we were 2 or 3 potty training. We don't remember how it just, we are able to do it. And it's harder as an adult, and now you have to think about it and learn it again. But that's the most effective treatment if it's a pelvic floor problem.
Could those, we've also heard about those Squatty Potty where they help the patient with a better alignment. Do those help in these instances as well?
Yes, they can help. So what's interesting is that we have the anal sphincter is continuous with a sling-like muscle called puborectalis. And that starts at your pubic bone and it's like a sling and it
Oh,
makes your rectum at a 90-degree angle. And part of the reason why we have that is to keep us from not going to the bathroom all the time. It keeps us continent. But when we relax it, it straightens out and the
makes
rectum gets
sense.
straight. And when you do a squatty potty, that position helps to straighten out the rectum. So it makes it easier to evacuate.
Oh, well, that's so interesting. I'm glad we talked about this. So, do you have any tips for patients on how they can talk to their providers about those options, even if they're taking something prescription, like how that could possibly work together?
IBS, I would say, is one of these conditions. And I would say, from a provider standpoint, one of the hardest aspects of IBS is unpredictable.
Hmm.
You don't know when it's going to when you're going to flare. And from a survival standpoint and a completely understandable standpoint, if something's unpredictable, you're going to have some worries, concerns related to the symptoms. And we call it symptom related anxiety. It's not like people have general anxiety. It's just natural, right? If I didn't know if I was going to have a problem, I would get worried about it. And these behavioral therapies can help reduce that stress and help that coping and management. If a patient's interested, they said, I know that there are some of these behavioral therapies that have been shown to be very effective. Is that an option for me? I'd like to talk about that. And now there's more information out there for patients. They're even having apps to be more readily accessible. And then there's GI health psychologists that help the patient. And they're not for the rest of their lives. It's a set period of time, 8 to 12 weeks. And then the patient can give some long-standing improvement of their symptoms.
Oh, that's great advice. And do you have any tips for, patients have to be realistic, what's doable for them with the options that are available, the diet, the mind, the gut brain interventions. And again, we were faced with these challenges because it is unpredictable and we have anticipatory anxiety about the symptoms. That's a great point. I've experienced that myself. So again, the ultimate $1 million question is, how do you know what's right for you? And how do you communicate that with your provider?
I would say information and education is your power. So first of all, need to find out more about, is this the right diagnosis? What are the modalities that could help treat my symptoms? And what am I interested in? And also that you want to phase it in. You may say, look, let me treat my symptoms. I need to manage them because I'm having them every day. But now I would be interested at the right time for the behavioral therapy. And then maybe I can get off my medicines. So you don't have to do everything at the same time. You probably just want to phase in what's your is your diet okay? Are you making sure you have fluids? Okay, let's talk about the different medications. And then some people are not. And then some people said, look, I want to be more natural. I'll go diet. And I'm really interested in gut-directed hypnotherapy. Or maybe I've used it for hypnotherapy for something else. And I'm really interested in that. I'm going to go that way. So I think it's all a partnership. And I personally do not feel that the provider should just tell the patient what to do. I think you want to empower the patient to hear about the options. What sounds right for you now? We can always go to something we could add on. We can use behavioral therapy and Ibsrela or, and diet. Everything's on the table. It's a matter of the timing and the patient understanding what they're doing. But I would say for medications, you'd want to do one thing at a time, because what if they have a side effect? And then you're not sure, and then it gets confusing. So it's really good to be a little more methodical about it. But I would want people to know that there's a lot of options out there, and they're available to you, and you should just know about them and then decide with your healthcare provider, what's the right one for me at the right time.
Oh, this is great advice. Well, Dr. Chang, I really appreciate your time today, as always. This has been so insightful, and I hope our listeners really take the time to listen to this episode and take your great advice. Thank you again for coming on today. I really appreciate it.
Thank you so much for having me, and I do hope it helps all your listeners.
Thank you for listening to the Gastro Girl podcast. For more information and resources, please visit gastrogirl.com. Do you have a question for Gastro Girl? Please email podcast@gastrogirl.com. The information, opinions, and recommendations presented in the Gastro Girl podcast are not a substitute for medical advice from your healthcare professional. Please consult a licensed clinician in your state regarding all matters related to your health.